Okay, so you're on your rotation reviewing a CT scan for, say, abdominal pain, and then you see it in the report, incidental pancreatic cyst. And your mind just starts racing, right? Is this cancer? What do I do next? We have all been there. Today, we're going to break down this super common problem by walking through the 2015 AGA guideline, giving you a really clear step-by-step plan. So here's our game plan. We're going to cover the 5 key stages you'll face. First, we'll talk about why this is such a common dilemma. Then, how to assess the initial risk. After that, we'll get into the surveillance plan. We'll cover the red flags that mean you need to intervene. And finally, we'll talk about when it's actually safe to stop all this follow-up. Think of it as your clinical roadmap. And just so we're all on the same page, this is our guide for today. Everything we're talking about comes straight from this key clinical document from the AGA. The whole point of it is to standardize our approach so we can make the best possible decisions for our patients. All right, let's kick things off with the core problem itself. Why are we seeing these cysts pop up so often? And what's the real challenge they present in the clinic? Yep, this is it. The classic scenario you will absolutely face if you haven't already. It's an unexpected finding on a scan that was done for something totally different. And the big question is always the same. Is this thing dangerous? And what on earth do I do now? Well, this guideline is designed to give you that answer. And get this, these things are super common. As our imaging tech, like CT and MRI, gets better and better, we're just finding more of them. We're talking as many as 1 in 4 people over the age of 70 could have one, which is exactly why having a standardized plan is so critical. Okay, before we jump into the recommendations, this is a really crucial point for you as a trainee. Almost every recommendation we're about to discuss is based on very low quality evidence. Now, that doesn't mean they're bad recommendations. It just means we don't have big randomized trials, so these guidelines are really built on expert consensus. It kind of highlights the art of medicine, right? So, let's get to that first major decision point. A cyst has been found. How do you, right then and there, figure out your patient's risk based on that first scan? Well, the guideline actually makes this pretty simple. It gives us 3 specific high-risk stigmata to hunt for on that radiology report. If you see any one of these, that's your signal to escalate the workup. This chart lays it out perfectly. This is your first decision tree. If you see a solid component, a dilated main duct, or a cyst bigger than 3 centimeters, the path is clear. The next step is an endoscopic ultrasound with a fine needle aspiration, or EUS-FNA. Seriously, if you remember just one number from this whole initial assessment, make it this one, 3 centimeters. It's that key threshold that immediately tells you whether to watch and wait or to dig a little deeper. Okay, but let's be real, the vast majority of cysts you're going to see will be small and won't have any of those scary features. So what's the plan for them? Well, that's where the surveillance protocol comes in. This recommendation is the absolute backbone of how we manage these low-risk cysts. For a cyst that's under 3 centimeters and has no other worrisome features, you don't need an invasive test right away. What you need is a solid surveillance plan. And here's that protocol broken down into 4 simple steps. After you find it, you get an MRI in 1 year. If nothing's changed, you can then shift to an MRI every 2 years. And if there are still no big changes after a total of 5 years, you can stop surveillance. The whole goal here is to monitor safely without over-testing our patients. So let's circle back for a second to that higher risk patient. You found a worrisome feature. You did the EUS-FNA, but the cytology comes back negative. Now what? The answer's actually pretty elegant. They just enter the exact same surveillance pathway we just talked about. A negative USFNA basically de-escalates their risk, and they join the low-risk group for that MRI follow-up. It's a nice little loop in the algorithm. Okay, so you've got your patient in a surveillance program. What are you actually looking for on those follow-up scans? Let's talk about the red flags that tell you it's time to step in. The key here is to watch for significant changes. That means if the cyst suddenly develops a solid component, or the main duct starts to dilate, or, yep, you guessed it, the cyst grows past that 3 centimeter mark, the surveillance plan is over. It's time to hit pause and reevaluate with another EUS-FNA. Now this is a big one. This is one of the clearest indications for picking up the phone and calling a surgeon. If you find both a solid component and a dilated pancreatic duct, that combination is a very, very strong signal for potential trouble, and the guidelines suggest moving towards surgery. And you need to pay attention to this, because it's one of the few strong recommendations in the whole guideline.
Pancreatic surgery is complex. It's a big deal. The evidence we have strongly supports sending these patients to a specialized high-volume center. It really does improve outcomes and reduce mortality, so it's a key point for patient safety.
Finally, let's talk about the end game. Every good plan needs an exit strategy, right? When can you confidently look a patient in the eye and tell them they don't need any more imaging? The guideline gives us two clear off-ramps from surveillance. First, if a cyst has been totally stable for 5 years, you can stop. Second, and this is just as important, you should also stop if a patient, for whatever reason, is no longer a candidate for surgery. At that point, more imaging isn't going to change your management.
And what about after surgery? Well, whether or not they need more follow-up is all about the final pathology reports. If they found high-grade dysplasia or actual cancer, you need to keep an eye on the rest of the pancreas with MRIs. But if the cyst was benign, no more routine surveillance is needed. They're done.
So there you have it. The 2015 framework gives us a clear, logical plan for today. But remember how this is all built on low-quality evidence? As our imaging gets even better and we learn more about the molecular markers in these cysts, it leaves us with a really important question. How is this whole algorithm going to evolve, and what will your practice look like 10 years from now?